Easter candy that maybe still exists. I don't know. And we'll get started relatively soon. Jake, I see that you're here. Are you going to be leading? Oh, we can't hear you, Jake.
Can you hear me now?
Yes.
Fantastic. Gotta love technology. Easter candy doesn't make it much past Easter in my house, Janet.
Same.
They pay a candy tax.
Same. Late nights in my household too. Mm-hmm.
Janet, I have a question for you before we attend the meeting. Are you getting my Medicaid, Medicare stuff from
Yeah.
Washington, D.C.?
Yes. And also thank you for the Mother's Day note as well. That was very kind of you.
Okay.
For everyone that is here, just for attendance purposes, do y'all mind putting your name and who you're affiliated with in the chat? This information will be posted, and we'll try to get things up by the end of the week. We have about 1 more minute, and if you don't mind, please putting your name and who you're affiliated with in the chat. That'd be great.
All right, everybody. Thanks for joining today for our Integrative Care for Complex Populations Collaborative. We'll go ahead and get started here in just a minute. I believe Janet's going to kick us off with a recording.
Yes, this information is being recorded and it will be posted on the website, hopefully by the end of this week. If not, then by the end of Monday. Jake, I'm going to let you take it away. And we do have a kind of full schedule, but I think we can be very flexible with some of the timing too.
Thanks, Janet. Feel free to hit the record button. Oh, you did?
We're recording.
Right.
Yeah.
We're good. Okay. I didn't get the notification, so that's good. For those that are just joining, welcome. Please add your name, pronouns, if you have any you would like to share, and who you're affiliated with into our chat. This definitely will help with our roll call, and we'll go ahead and begin. By starting off with our introductions, I'm Jake Vandermeer with Pacific Source Health Plans. I'm one of the co-chairs. We also have Janet Herb from OHA on, as well as Walter Berksmeyer, and I probably butchered his last name for like the 10,000th time, from Care Oregon.
Hi, everybody.
Joining us today. As far as our agenda, we have Jennifer Valentine on in regards to updates on the MOU. We have Cassandra Laveau, and I apologize if I mispronounce your last name, or Laveau, HCBS team Imagine, and that's to go over the 1959 populations. And then understanding 834 with Mary Durant and Stephen White. And then we'll open it up for public comment if time permits from everybody. And then just so everybody's aware, our next meeting will be August 12th following this. So we'll start off though. Do we have Jennifer Valentine on?
Yes, I'm here.
Jennifer, I will let you go ahead and take it away. If you have something to share, you're more than willing to.
Okay, so mainly today, wanted to take any questions on the upcoming MOU report that is due later this week, if there are still any outstanding questions. There was a little bit of confusion we saw with people pulling the wrong MOU template. There was a CY 2024 template added to the CCO forms for the report that has changed some of the categories. We removed a few, we updated a few. So make sure you you are using the right template, or we will send it back to you to complete the updated template. Again, that is on the CCO forms page. The MOU guidance, which I'm going to do a share switch to, was also posted there for the MOU report. As many of you know, we've kind of been waiting to see some improvements in your data tracking systems to get better better data. Let's see if I can find my stuff here. Too many things, I think. I'm gonna try to switch screen. So hopefully you can see this. This is the CY 2025 annual report and guidance document, which again is posted and was sent out back in February, I believe. So this mostly kind of has similar things from, again, there's two separate guidance documents. There's a guidance document for the MOU itself, which is about shared guidance with the triple A's for the fields. And we are in the process of reviewing those MOUs that came in the end of March with our APD teammates at the present time. So we are doing that. And then these reports on the CY 2024 calendar year and all the actions from the MOU are due. So this has a lot of similar things. The big thing that was updated here was the focus here on the updated links to your care coordination rules. So the care coordination rules that were updated and posted live in 2024 and 2025, those changes were highlighted in this section compared to what was previously posted in the older guidance for the reporting. But the domains of the MOU and the reporting are the same. Many of the actions are the same, but this kind of provides a link back to each of the main CCO care coordination rules and the links to the MOU. So far we haven't heard any comments or questions come in around those things. We did want to also highlight, because we heard it was a question that came up at one of the CCO care collaborative meetings, is that you know, you do not have direct access to LTSS service plans in your when you're building collaboration. The goal is that you're using your MOU process to have those sharing of prioritization, sharing of information for those members with your APD or other LTSS members. So you're not going to be able to just use them to risk prioritize for every member unless you are communicating. Now, there's a few regions that have indicated they now have a shared platform like Activate Care, where the APD offices are uploading some of those service plans so that they can be integrated more into care planning. But again, this is going to be part of that MOU process that you really, as you go forward, to realize that as you're looking to prioritize, and, all members who have LTSS must have a care plan developed, annual care plan, and then, how are you making sure that care plan is incorporating any changes? One of the new things that was in your 2024 rules that goes live this year for that report is your 14 days post-care setting transition interdisciplinary team meeting that is supposed to happen for all members who have any care setting, not just hospital discharge, not just SNF discharge, but any level of care from an adult foster home to home, or the SNF to home, those kinds of, there's supposed to be an interdisciplinary team meeting called for all of those care setting transitions. So that's a new reporting item. And again, we've heard from a few folks that you missed setting that up perhaps to capture that data. So we'll be looking at that data this year as sort of the beginning of that, but then that data will continue in the future years. So in any case, those are some of the key items with the reporting that's due. The template itself, like I said, is pretty much the same. You've got a couple of measures that are, and there's in this document, the guidance, there's a highlight, I believe, of some of those metrics that are slightly changed. They're bolded here. These are the number of members receiving that post transition meeting in the transitional care domain 4. This is separate from a normal just IDT meeting that you're calling to look at sharing prioritization or sharing sort of for other members. These are the actual post within 14 days of that care transition. And the percent of those meetings that included the member or the member's representative in that meeting is also kind of, because still the goal of trying to increase member engagement in your work with members still continues to be that APD has historically engaged members quite significantly in their own care planning. They have mottos around nothing about us without us as part of the disability equity lens. And we in the medical world, we've often made a plan, talked to the providers who say this is what's best, and then we tell the members, here's your plan. And so we're trying to make sure there is that open opportunity for members to be more engaged directly in their own planning. And when they are unable to, that we are inviting those other folks. One other thing I want to switch to, let me know if you can see this switch. Can you see that switch? So this was the slides that were presented in February, and just one of the other things, let's see if I got to move some things around here. We talked a little bit about one of the things we're trying to monitor with reporting. Here's the example of the total number of members with LTS with care plans compared to the number of people who had LTSS and either 4 or more chronic conditions, LTSS and SPSMI, or LTSS and chemical dependency. And in almost all the cases of all CCOs, the number of care plans for members with LTSS was lower than that level of members with especially 4 or more chronic conditions. So one of the things is to think about LTSS as, it's not only LTSS, it's that this is a sign that someone needs a lot more and that they probably have a lot more going on. Once they've already needed and shown that they're in an LTSS program, they often are managing many, life-challenging issues, disability, that kind of thing. So, that is one of the reasons why CMS is so hot on making sure that We have strong focus on members with chronic conditions and LTSS. And that's what's in the rule, is any member with chronic conditions and LTSS. It's in the federal rule and it's in your rules. We also tried to look at tracked referrals last session, and we had very low numbers of referrals back and forth. We still have a hospital discharge bill sitting in Ways and Means, has a lot of expectations of the legislature that we're going to make improvements in our ability to for not only ODHS to better track and respond to those referrals, but also that we are actually making referrals. The number of members who are being hospital discharged but not getting referrals to see if they could qualify for any of these programs is still pretty disparate in the data that we have. So, looking at making sure anytime you have those discharge notifications coming from your hospitals via your point-click care data, are you making that connection to your field offices to say, hey, this person might need an assessment? So just really staying on top of those things and trying to better data track. Maybe this is a data tracking system for your referrals, but referrals have been required in OARs since 2017, since the managed care rules came out, and our data doesn't look like we've been tracking it very well. So, and now we've had 3 years of CCO LTSS reporting in the same format. So hopefully by this 2024 data is going to look a lot better than this. That's what we're all hoping for. Again, these are just an example of one CCO and looking at the level of care plans compared to the number of people with LTSS. And again, another example of a single and breaking this down in duals and non-duals, because many people think, oh, it's only the dual eligibles, the older people who have LTSS. We have a lot of people who are younger with disability. It could be a behavioral health disability that they need, like the Comagin programs. Are you referring? You're going to hear from Comagin. Are you communicating and working with not just APD, which you have an MOU, but you've got all the DD programs with ODDS and their local disability offices, and you have Comagin with behavioral health. And are we really building those relationships with Comagin so that you can know who is in those programs and what those programs have to offer members that you may not be referring to them who might qualify for those programs? So looking forward to hearing that today. Okay, so then the other thing is, again, we were looking at in the past the triggered communication out of point click, which we were able to pull. And for most CCOs, you had a lot of communication coming out of point click. This is one CCO example. And the number of times that triggered actual communication with APD was almost none. So, this is where you have this huge opportunity for improvement in alignment with these new rules and your new risk scoring. There's just some real big opportunities here. The other thing is and you're going to hear from some folks about LTSS indicator, but we've talked about this before, that we've spent the last year meeting with the APD and the ODDS folks, and also met with the Comagin folks to try to work on improving this data for you so that you're getting better data. And we have found some issues. There are some old codes in the system that we were told are no longer being used by, and they could be phantom codes, like someone could have been in that program 6 years ago, and that code will still, no one took it off because no one uses that code anymore. So we want to update those codes. I'm meeting with the CCO team to try to move that change request forward to fix that, and also to get you the actual program name sent to you on the 834. Right now, you just get a yes or no, because we all know that it's very hard to risk score someone in your work when you don't know if they're in a nursing home or if they're in a developmental disability at-home program. And so what we really want to do is be able to give you that cheat sheet. And I know many of you have been asking for this for many years to get better data. So hopefully our CCO team will approve that work and we can move that forward. So that's kind of where I am today, is just, we've done a lot of that prep work to move that forward, and we're getting ready to look at your new reports coming in, and excited to see some improvement this year. I know it. I'm feeling it in my bones. For many of you who've been telling us you've been working on getting better data to us. So, to be able to do these reports. So that's kind of my thing today. Do you have any questions at this
Yeah,
point in time? I will
Jennifer.
close. Yeah.
Sorry, Jennifer. There's a couple of questions in the chat for you. One is from Care Oregon. Can you confirm again if we're supposed to use the calendar year 2024 template or 2025?
The actual guidance says 2025, but the template was posted, report template was posted as CY 2024. Their only other template that's posted on the forms page is CY 2022. So the form that is posted on the CCO forms page, it says LTSS report template, and then it has CY 2024, which is really about the updates for the guidance for this year. I had to go look at that myself when someone said, where's the 2025? Because I didn't post it, and I can see the confusion because it's due in 2025, but it's 2024 data, so the CCO team posted it as 2024 data. So that's why they put it that way.
Okay.
Any other questions there?
Yeah, there's one more from Ellen. Has there been, or is there a way to cross-tabulate duals with those who have requested and whose health status qualifies them for HRSN?
At the present time, that is not part of this reporting. There's other work that the CCOs are doing, and other reports that go to management, CCO team leaders, that the CCOs send. This specific report is only about what is required in the LTSS guidance documents around what the MOU actions and reporting on actions. So it's things like sharing a prioritization with the local APD office or AAA office, ways to make these referrals back and forth and track them. How many IDT meetings were members engaged in those IDT meetings, and what percentage of those meetings engaged members in their interdisciplinary team conferences, how many members are receiving their care plans, how many people at discharge are receiving discharge plans, how much communication at discharge is happening with APD, AAA in the MOU. So these are really about the MOU. But one of the things is we've also said long term is that what's in the MOU for APD, it's because the legislature asked us to do that back in like 2013. Much of what CCOs need to be doing for all members with LTSS under new rules can also be processes that they apply to their work with any ODDS client and any member who has a Comagin service like the 1915I program for behavioral health. So those kinds of home and community-based support programs and that kind of thing are all, just to think about what you are doing, even though you're not going to report that on this report, because this is about the APD AAA MOU, is to think about that process being really similar, and where the updates we hope to make to the LTSS indicator information will also support all of the program data. Although we do have a problem right now because codes that used to be used when the 1915I programs were in OHA no longer are being used, so we don't have the easy way to include that on the 834. So it's going to be more critical that you listen to and talk to Cassie about how you're going to be able to build that data connection to your CCO directly for members who have those programs or who need those programs, because we don't have a way right now of seeing a code in MMIS that we can translate to the 834. And the 834 is really pulling data out of the MMIS system. And that was one of the other reasons we met with the AAA folks, the APD teams and the ODDS teams, is to make sure the codes they put codes in the mainframe and the one system, and to make sure we knew what codes are still translating into MMIS that we can send you, because we don't have access to what they put in. And you don't have access to that, but the translating system is what goes from their system into MMIS, and then we can send to you. And that is something we don't have for right now for the Comagin program. So I'm just setting Cassie up for a good conversation here. So, and with that, if there's other questions, I see George has his hand raised.
Yep, George, you're next.
Hi, Jennifer. Question I want to address to you is, there's been many consumers where they would go into a doctor's office and such, it would be doing stuff, and they would come back and find out that when they get a bill, they're being charged wrong on their codes. Is there anything that a consumer can do? And if so, can the CCOs or the state help them in a way to understand the codes when they're being charged wrong?
Well, first of all, there's different types of members in terms of so if someone has Medicare and they have OHP, state law does not allow the member to be charged anything until the Medicare has been processed. And then if they're a full dual eligible, the CCO is responsible for the cost sharing. So there should be no bill to the member. Any provider who is telling members they have to pay up front. We've had this issue before with dual eligibles where a provider says, I need your 20% before I will do the surgery. That is illegal under federal law. And we have folks in provider services who, those providers should be referred either to the CCO or to, provider services for follow-up. And the member should contact like our ombuds team if they have issues, so we can follow up with the provider. Now, there are people who have Medicare only, and those people then have bills that they are going to owe 20% unless they are a qualified Medicare beneficiary where 20% gets paid, the 20% cost sharing gets paid by OHA. But that's there's different groups. And then certainly with CCOs, we have no copays for services. The other thing is for both Medicare and Medicaid, if a provider is going to provide a non-covered service to a member, they're required in advance to either use the OHA form or the Medicare form. The Medicare form is called the Advanced Beneficiary Notice that says, if you want this service from us, this is a non-Medicare or non-OHP covered service. This is what the cost is going to be. And they have to give that to the member prior to the service. If they give that to if they don't give that to the member prior to providing a service that is not covered, the member is not liable for that service. So again, that's for OHP or dual eligible members. And we're happy to work with any CCO or folks out in the field, our ombuds team, if they have issues pop up with providers, and our great provider services team. So, so for now, I do see Ava has a question. I'll move to that.
Hey, Jennifer. Thanks for facilitating this conversation, going over the document. I just had a quick question. We've been meeting with our central office and some of our local branches of APD and AAA, and they're really saying that they're under-resourced to be able to do some of these expectations in the MOU. I mean, they understand they signed it, and so I was curious, when you're meeting with folks kind of at the state level, kind of representing those services, is that conversation happening? I think it's somehow related to the not having funding for some of the LTSS positions they had in the past. And so, I mean, it kind of reflects somewhat in our data. And I'm just curious to know kind of your thoughts based on kind of the state level.
Well, I think the focus at the field offices is to at least handle the basic expectations of sharing prioritization information and taking referrals, and if you have a sharing process. But I do think CCOs sometimes expect more from the field offices, like they're not always going to be paying attention to the point click data like you are. They're not going to know that someone is discharging necessarily unless they get a call from the hospital to do an LTSS assessment. So there needs to be a sensitivity to the fact that their role is different. They are using data differently. And what are we looking at is, that what they can provide you. They may not have someone who's going to sit and upload data into your electronic system, even if you give them access to it. So, hey,
Totally. We understand that.
We've
Yeah, I think it
added
was
you
more
to
around the
our.
sharing. I think it was more around sharing care plans or being invited to like IDTs, to talk about shared members and resources available through their systems, and not always having that capacity.
Right. Well, I think part of it will be is trying to connect, if there is an issue, is to make sure that you can notify us if, that the field office or the field offices contacts the APD state office. I don't think that's what the state office has been hearing. They have been hearing, yes, that, in some places there's expectations that come in the MOUs. One of the challenges, like in reading the MOUs right now, is, we want to make sure like the MOU's language wasn't written for the APD office, that the APD actually wrote their own actions, and sometimes the expectations sound like they were written by the CCO for what the APD would do without really making sure that it was realistic for the APD. So, it is a challenge. I don't know how their unfunded limited positions are they will change when the new budgets come out. Those are some things that we are all, like I say, waiting to see. I think everyone asked for more staffing for the hospital discharge bill to be implemented. It's sitting in Ways and Means along with many other things that are sitting in Ways and Means and will probably be decided in June, right before they close up. But that hopefully will bring us some more focus as well for both sides of the agency to be able to put some resources toward that, shared processes and those kinds of things. So one of the things is, if you're running into phone call issues, you should try to use an electronic email system. And if you're getting no response, that if you get 5 requests and you don't get a response to do assessments, that is something that we should then connect with the state office on, because we want members to be able to access those assessments. There are some delays, and that's one of the issues of the hospital discharge piece, is that we've had delays in discharge from hospital beds for members who are ready to discharge because the assessment details have not been completed. One of the things they want us to look at in that whole process is creating potentially a presumptive eligibility process for LTSS, similar to what we have for hospital presumptive eligibility, right? So when someone enters the hospital, we can say, okay, we are pretty sure, even though we've still got to do all the asset verifications or whatever, we're pretty sure this person's going to qualify for OHP, and we give them OHP at that hospitalization. That really has helped hospitals over the last, I don't know how many years we've had it, at least 8 to 10 years. You know, the similar idea of, can we do that for members needing LTSS, have a presumptive eligibility process so that those folks can move more smoothly into LTSS supports, and then not have the providers or the members held liable if it turns out later on when they do a full asset assessment. But one of the other things is, are there ways to look at if someone qualifies already for SNAP, that, you know, we shouldn't need the same length of LTSS asset assessment. And so I think some of those things bog down the LTSS system right now in timeliness of being able to respond to the volume of requests. So, so part of it, as I would say, don't just use phone. Have a paper trail where you can then send follow-up. Find out who the managers are at those field offices. As part of your MOU, you should know who those managers are. And if you're, you know, you got 10 requests that went in and 2 weeks later you haven't heard anything, that's a good follow-up for, you know, working with the managers. I mean, we want to hold them accountable as much as we also want to make sure we're, you know, because of the time frames of when people work or don't work. You know, some of them are working like 6 a.m. to 3 p.m. or whatever. So you send something at 5. Did they get your phone message? I think phones in general are terrible ways to track messages these days. So you know, having that electronic system, I know some of you are now using like an APD referral form. So they know what this, you know, this form is filled out. It has all the data they need. They get it. You know, so those kinds of things, that's part of the MOU process. Can you make it easier for them, so that it's not like, oh, I got to follow up and get all that information? Can you send them all the information right away when you're, you know, when you're making that request? Can you get them all the pertinent details? Hazel, I think I see a question from you.
So I just more of a comment, and then it was really helpful to see those slides that you posted, right, to understand, you know, that data. And I think there's multiple things happening, right? There's you know, staffing shortages, but also when you go through that LTSS training with the APD offices related to that referral process, we follow their training standards, and then we send those, complete those forms and send those to the APD office for those referrals. But not every member, because I think what you alluded to, right, is that they have a very strong member focus, right? And so not every member wants to move ahead with that referral. And sometimes what I've seen in cases is that it takes members a little bit of time to recognize that they maybe need those services, right? And so it becomes challenging because we can initiate those referrals, but they have their standard process in terms of their response time, right? Because if a member doesn't engage, they have to move on to the next referral, which makes sense. And it can be challenging. Our team does follow that. Should a member, you know, have a change, or even a change in circumstance, like they think they're going home and they're going to be okay. But I think that there's just so many layers to this, where not only is it there's still challenges getting all of those assessments completed, because they have timelines that they're following, but also members themselves, you know, aren't always maybe to that acceptance level of that they're going to need that level of support. And so sending a referral for every single point click care notification, I don't think is reasonable, because our members may not want to engage in that. You know, they have a myriad of reasons why. It could be fear, you know, concerns about what they're potentially losing in terms of independence and on and on. And so we spend a lot of time helping educate members about what those services look like and how they can benefit from engaging with that team. But it can be very challenging to move a member along in that process.
Well, and that's fantastic to, point out. Again, that's part of the, not just the stages of change, but the, the other systems that look at member readiness, but, also a great place to look at when you're doing discharge planning with members. Are you following evidence-based discharge models, which do a lot of patient education, which help them understand, that also help them, look at, hey, this is a benefit you get, like, you have the access to this. This is a costly service, like to have someone come into your home and help you. A lot of people, yeah, maybe don't want someone in their home or whatever, but it's partly that, and using your community health workers or your other traditional health workers to support members, also in the discharging process. It's why we have that, why that 14-day thing is so important to your following up after did they go to their appointments? I mean, that's another thing. Are they, a lot of times an appointment is made for them. Are they getting to that appointment? To see the behavioral health provider or to see even their primary care doc, or, there's a lot of follow-up. The hospital's expecting they give them a discharge plan, it's just going to happen. But part of the reason people end up back in the hospital is that they haven't really absorbed it. And we have to realize as humans that anytime you're dealing with a change in your function and your ability, you are going through stages of change. You are dealing with all those stages of grieving. Like, I am grieving the fact that I no longer am so independent. I am grieving the fact that I never had to take any medications and now I have to take medications. That puts you in a different mindset. And the more that we can remember, members have a lot that they're going through, but that is why this population is so in need of supports, and we don't want to forget about them, even if they're not right there right away, ready to jump into these services. So appreciate that you're looking at all those things, and we're happy to try to support any dialogue you're having with your field offices. If you feel like there's a backlog, we can get our teams at APD on, and just like you all have challenges trying to do all this work for all your members every day, it is sort of the sign of the challenge for them as well, that they've had a lot of staff turnover since the pandemic. They're trying to up train people into the one system still. I think they're getting, much more savvy with that, but just all of the things. We're actually been working on that with them on choice counseling issues. They're building some new choice counseling training tools for field offices. So there are these positive things happening. And again, and then the other thing is hopefully we can get you this better LTSS data so you have more of this data yourselves. I mean, I think some of you have relied on getting data directly from the field offices, and not everyone gets that data statewide. There isn't a statewide system out of AAA. It's not really their job. It's CMS requires OHA to make sure we get that data to you via the 834 is how we decided that we were going to get you that data back when CMS started requiring that. But we need to do a better job on our end to fix that data. And so, hopefully I will get the support of our teams who need to do that work and get that positive change out as quickly as possible. I don't know how long 834 change is going to really take. Many of these change requests take a full year to get implemented when they are moving. So we need to get to that stage. And again, you'll be hearing more directly from Stephen and Mary about things about the 834. But again, we can only provide data that is in MMIS there, but we also need to make sure, like, we look at the list, and there's program codes that aren't reporting on there. So there's programs you don't even know about that members in, which I know some of you have been calling us and saying, we have data discrepancies. So, this is what we're trying to do on our end to try to make improvements, and hopefully I'm a policy analyst, so I have to send it up the chain for supports to make it happen. So anyway, I think I'm out of time, or just about, so I better run and let you get to your next thing. So anything else that pops up, you can always contact me directly, and we'll be starting reviewing those new reports once they start coming in. I think the 15th is Thursday. I will not be looking at them till Monday, just as for because I will be out of the office on Friday this week. So if that's a help for anyone who's struggling to get that last bit of the report done, I'm not really going to start pulling them down till Monday next week. So have a lovely rest of your week here. And this meeting has got a lot of good stuff, so I'm going to stay on and listen.
Thanks, Jennifer, for your contribution to the meeting, as well as all those that chimed in and contributed to the conversation topic. So very much appreciated. I wanted to check in on time. I know we're a little ahead of schedule by a few minutes, but do we have Cassandra on to cover HCBS team and CoMagine?
My understanding, she was coming from a different meeting and would be here right at 2. So if
Okay.
Stephen and Mary maybe wanted to pop on early, if they're up for the challenge.
I did see them on, so we can leave that up to them if they want to chime in, or we could take a quick intermission for 13 minutes.
I think I'm good to go if I can get my technology working. Let's see. Can you hear me?
Yep, no pressure, Mary.
Okay. Good golly, I just set myself up at the HSB, so we'll see. I also have something I would love to share, so let me see if I can get that going too. I think I moved the wrong thing. Get everything out of the way here. Are you seeing a spreadsheet?
Yep.
Okay. So the 834, for those of you who aren't aware, it's a file that we use to send data to our coordinated care organizations of who is enrolled with them. And then it contains a bunch of demographic information about those folks. The 834 is a national standard format controlled by an organization called X12. It sounds very stealthy and very, secretive, but it's not secretive. It's just very controlled. And so within that, we don't have a lot of flexibility with how we can utilize that file. There is a lot of requirements and rules around what we can send and how we can send it. So we do send the data. I've taken one of the files and my team has stretched it out, because if you were to open an 834, it is a long string that a human doesn't really read. The CCOs take these files down and they have processes that pull them into their systems and utilize them pretty much electronically. When there are issues, a person would maybe go in and look at it using a similar process as I've done here, where they separate it into the loops and segments. That's what pieces of the file are called, loops and segments. But if you were to separate out these loops and segments, the information that's in the file is what you're seeing here on the left. And then what my team has done on the right is tell you what that is. So you'll see on the top what this file is. We have daily files that go to CCOs, and then we have monthly files that go to CCOs. The daily file is how we tell them additions, terminations, reinstatements, and changes. And then there's the monthly audit file, which is what this file is. And that's where we tell them everybody who is enrolled with them as of that date. So then they can audit their records and make sure that of all the additions, terminations, reinstatements, and changes we sent them during that past month, everything equaled out, and they have everybody that they're supposed to have. And if there are any sort of problems, they can then work with us to get those sorted. So as you'll see, I've done my best to de-identify this record, but don't take any copies because I might have missed some stuff. So you get this sort of demographic information, date of birth, how much we pay the CCO, their addresses, and a bunch of this sort of routine information. If they have other insurance, which this person that I had my team pull does have Medicare, so it's got their Medicare Part A, Part B, including their Medicare ID. This particular person also has some other insurance outside of Medicare, so that's included for the CCO. And then it's also got some information about who the person's caseworker is and what their benefit plan is on the Oregon Health Plan. When they're set to redetermine, this is quite an old one that my team pulled, so clearly this person already, I'm sure, did redetermine what language is their primary language, their racial identity, their ethnicity, whether they've identified a disability. And then you'll see right here on line 80 is this one little field that says LTC LTS, and then the next line has a Y. This is all that the CCOs are currently getting related to LTC, LTS, and it's either a Y or this is not present at all. So they don't get a Y or an N, they get a Y or the absence of the information. So there isn't any qualifying information or additional detail. It's just the Y or nothing. There is the potential in this part of the file that we can add additional details as long, excuse me, as long as those details are in MMIS. The 834 can only send out things that are in MMIS because it is directly created from MMIS. If the information is in a source system, but not in MMIS, we have to get it to MMIS first, and then we can send it. So that's where we have to do that work with Jennifer for her change request to make sure what we want to send first is in MMIS, and then work to get it in the 834. Then once we do that, we have to test with our CCOs because since their systems are pulling these files in, I like to call it automatically, they have to do coding on their sides to accommodate that new information. So it's a lengthy process to get each of those steps done, but it is definitely possible. And I think it's been being discussed for a while. So the team in our BSU will work with Jennifer and possibly Stephen's team and my team to get it all documented in what we call a change request. And then we go through a prioritization process to get us on the schedule. And then we can get it moving so that we can hopefully share additional data besides just this why. So that is the 834. And I am open if anybody has any questions that I might be able to help with, or Stephen's on as well. Sort of the breakdown of the 834 is my team does the technical parts, the format, the delivery, the mailboxes. That's how we deliver them as electronic mailboxes, that part of it. And Stephen's team sort of oversees the content. His team are the experts on all these actual data elements, but we work very closely together. So that's why we're tag teaming this topic. But if we have questions, one of us will be able to help.
Thanks, Mary. Huge Pearl Jam fan, Christy Swank at Moda has a question.
Thanks for the intro, Walter. Yeah, so that was actually very helpful to see kind of how the 834 file worked. I just had a question. I've talked to several people at OHA about the LTC flag, and discovered that most people with APD don't have that flag. So I'm just wondering, is that not in MMIS, and how? Because we've been trying to figure out how to get a comprehensive list of people on APD, and we get a sort of a comprehensive list. I mean, basically, we get a list from our APD office of people with APD as long as they've had like a ED visit in the last year. So it doesn't
Yeah,
include.
This is Jennifer. If I can jump in and just say, in the LTSS in the guidance document you have, there's a list of the programs that report. In the presentation we did in February, we went through a list of the programs that can report. And that's part of the update, is trying to get more of the programs that were left out. Part of it was when we were doing this process back when we were making lots of changes, we had a lot going on at the agency trying to update us for the new managed care rules. And we had the system changes starting, and we had the team working on the definitions and working with CMS on what had to be in the rules. And some programs got left out. So that is really why it's so critical that we get this update. And then, like I said, the 1915I programs with the Comagin, they stopped using codes that are in the system in MMIS, so there is no code that we can use for that program. So we have to have an alternative way for you to talk to the Comagin folks to get that information. But yes, there are programs that are not currently reporting, and that needs to be one of those fixes. And then, like I said, I think DD told us there's some program codes they no longer use that may be phantoms in the system that you're still getting reporting on someone who may or may not still need a program or be in another program, but they have a program code that was put in the system years ago, and since they've gone to one, they don't use those codes. So that's been part of this process of meeting with them to try to update with what are the current codes, how can we give the MMIS team the most updated list of codes that are in the system that can report. Shauna, I see she's on this. She sent me last year a list of here's all the codes that are in the system under what we call LOC codes. Those are program codes. And so, ideally, we're going to be able to see that improvement by updating. But in the present time, these communications that happen via your MOU with sharing your prioritization and, reaching out to your partners to clarify, it is unfortunately a time-consuming process for you all, and unfortunately what has to happen right now till we try to make those changes. So it's probably never going to be perfect, but at least if we can make this happen, and then also you'll have a list that says, okay, this person has this code, meaning this code is a nursing home facility code. This one is a home and community-based services code, and I'm going to have to work with this team of folks. So then when you need more info, you'll also know where to go, because you'll have this list of, when I see that code, I know it's this program, and the people in my region who do that program, maybe it is the local county DD office, maybe it's Comagin, again, so that you have the right place to go to do that coordination. So not all the members right now being reported are APD members. Some of the programs that report are DD programs. So when you get your numbers, that's also one of the challenges, is to realize that some of the programs are not APD programs. So when your numbers don't match what they have, we've had both cases where someone says they have a lot more members than we are seeing, and then we've had the opposite where we have more members than they have in their system. And so, again, the best we can do is try to improve this data so that you get a more comprehensive picture, but it isn't there at the moment.
Okay.
And
Thank you so
Christy, I think it might help us when we go through that prioritization process. One of the questions that we answer in that process is CCO impact. That is part of the prioritization. So hearing that and knowing that for me, how much manual work and how much additional effort that's taking, that's going to help me. So I'm glad that you shared that, because when we go through that process, I can add that in. And that does help us to know that and to be able to represent that. So we will use that when we go through that process.
Okay, great. Thank you so much.
Wanted to check and see if anybody else had any questions around the 834 for either Mary or Steve.
Either I did a great job or I befuddled everybody. It's one of those. I don't know which.
I put a question in the chat, but it's kind of about this because the 834 gives us, that they're in a long-term care setting and potentially, I think I heard you say that, like what kind. But it doesn't tell us like if someone moves between care settings or to a new care setting, and is there a report that comes out that gives us that data?
Right now, you should be looking at your point-click care data. You have the ability, some of the CCOs have not yet fully set up the use of the SNF notification system. So that is one place where you should be looking at the SNF data. That won't get to all care settings, but it gets to all the skilled nursing changes. And then you have your hospital notifications. So that's not all of them. The other things are like the adult foster home changes or things like that. And the only thing that helps with that is having really good relationships at the local level so that you can really try to be aware of that when it's happening for members. Other things are, your providers may be able to clue you in if something is happening for a member. So making sure you have a way to track care setting transitions and referrals for members going through those types of transitions. But the main ones you're going to have are you're going to get notified through your point click data. And there's a lot of data going into those systems now. There's a list of all the nursing homes in Oregon that are reporting, and you can get that from point click as an update. We usually try to get it once a year and send out to like our DSNP plans because they have to federally report on that data to us around how they're using notifications to support members in nursing facilities and their care setting transitions and things like that. So that would be the first thing, but your relationships are where you're going to best hear about those things.
So I think what I heard you say is outside of nursing facilities and transitions from hospitals, that we should be expecting our local offices to be able to provide us information when someone changes from one care setting to another.
Ideally, that would be part of your ongoing relationship communication through your MOUs, to be able to have them tell you. I know some of the MOUs say that. There's one region that clearly called out that they have a process that they try to have a 10 days prior to any transition. They tend to notify the CCO. So that's an action they have in their MOU. So they've clearly discussed that process. So that's kind of the goal of the MOU, is to try to look at those places where you do need to participate together as much as possible. There are also state hospital transitions out of state hospital to other types of adult foster long-term care that are on the behavioral health side. So hopefully there's some other opportunities. Maybe Cassie can help share some other insights into that system. We don't have a perfect system, and MMIS only has data that goes into MMIS. It's just like chronic care claims data. You have better data on your members' chronic conditions than we can give you out of MMIS. There is no way in MMIS to track whether someone has heart disease, or because it's not a it's not a system that is pulling that data and pulling that out to the 834 and marking people. So your claims data and other things like that are other ways to track and monitor your chronic conditions data and that kind of thing. Your ED visits, your primary care provider conversations, all the places you can build in places where those kinds of systems can send you information that you can use to have a comprehensive view of a member. It's a challenge.
Thanks, Jennifer, for commenting on that, and Jessica for the question. Any other questions or comments around understanding 834? All right. Mary, Stephen, thanks for joining us today. We greatly appreciate it. And I believe I saw Cassandra join. And thanks for giving us a little bit of grace and allowing a few others to jump ahead of you. And so you are, I believe, one of the last items on our agenda with HCBS Team Comagine. So I will hand it over to you.
No problem. Thanks, y'all. As Jake mentioned, my name is Cassandra. Y'all can call me Cassie. I use she, her pronouns, and I am the Home and Community-Based Services Policy Manager here in the Medicaid Policy and Fee-for-Service Operations team. Just to give y'all a little bit of background and context, this team that I am leading right now is a new team. Obviously, our home and community-based services programs are not new programs, but the existence of a team that is really dedicated solely to home and community-based services is fairly new as of September of last year. So a good amount of the work that we are doing is really trying to really get our arms around the scope of historically what has happened with our 1959 program, places where there are gaps that need to be filled, and opportunities for alignment with our partner agency at ODHS, as well as with our other partners, including CCOs, CMHPs, other behavioral health providers. We are going as far as making sure that we include safety net clinics and providers who treat individuals with co-occurring mental health and intellectual and developmental disability needs. So really, we are working to understand the entire universe of 1959 home and community-based services. So it's just a little bit of background. My understanding is that there is a desire to understand the connection between CCOs and Comagine as it relates to the care coordination for individuals who are on or receiving 1959 services. And this is something that my team and I have identified as a need to create some more structure around. Oftentimes, the 1959 home and community-based services are provided as carve-out services from the CCO service delivery model. So they are provided on a fee-for-service basis. And I want to at first kind of describe the role of Comagine Health in this process. So Comagine is our independent qualified agent. They are responsible for conducting the functional needs assessment and helping OHA in determining the eligibility of individuals for 1959 services. That includes verifying that someone is over the age of 21, that they have a diagnosed severe and persistent mental illness or chronic mental illness that has been documented within the last year, and completing that functional needs assessment, which to be eligible for 1959 services must show that someone is in need of support for at least 2 activities of daily living or instrumental activities of daily living on a 30-day basis. So if all of those pieces are in place for an individual, Comagine does recommend that they be approved for services and services be authorized. And that is just the first step. And actually, it's probably even not the first step because, as I mentioned, someone does have to have a diagnosed severe and persistent mental illness or chronic mental illness. So for a lot of folks, they are starting even before the eligibility determination process with getting the other required pieces in place. It also is, possible that someone might need to apply for the Oregon Health Plan before becoming eligible. So there are even some additional steps before the eligibility determination process takes place. Once that is completed, a person-centered service plan is completed in conjunction with the individual receiving services and anyone that they would like to be a part of their care plan. So that could include a guardian, a family member, a primary care provider, a behavioral health provider, anyone that is really integral or critical to that person and the services that they are receiving, the frequency at which they are receiving those services, the settings in which they are receiving those services, which can range from being in their own home and receiving personal care services or habilitative services to residential settings like a residential treatment facility or a residential treatment home or an adult foster home. And once the person-centered service plan is completed, that does have to be updated annually for an individual. It can also be updated at an individual's request, especially if their needs have changed, particularly if they have increased in acuity and they need to be reassessed. A lot of times this happens particularly for folks who are in residential settings and needing additional support from residential providers. So we do have quite a few reconsideration requests that come in through that avenue. And then at that point, once the person-centered service plan is completed, then an individual hopefully gets those services rendered. We know that across the state, there is a pretty severe shortage of behavioral health providers. So for folks who need psychosocial rehabilitation services, or for some folks who need habilitative services, those can be difficult to find and to locate. We also do have a shortage of personal care attendants, which provide those in-home services. And that can also be really challenging for folks to navigate. Where I see the connection is to CC for CCOs and Comagent Health is really in the process of making sure that once that person-centered service plan is completed, or being a part of that person-centered service plan completion, right? Someone who is intimately aware of some of the things that were being talked about earlier, someone's potential physical health diagnoses or other factors that are impacting their mental health or their behavioral health needs. That is a really critical piece of making sure an individual is matched with the appropriate services and the appropriate rendering providers. And on the OHA side, comparatively to our partners at APD and ODDS, there is not an overarching case management system or process that really documents all of those things for an individual receiving 1959 services. We can go in through like the one system, or to some extent see what's been rendered in MMIS, but really there is not a way for us to comprehensively look at an individual in one system, not the one system, but in one system, and identify the different places that they have had touch points with home and community-based services, where they have maybe tried to access services and not had any luck finding them. And because of that, we really rely on the partnerships that we have with county mental health programs, exceptional needs care coordinators for folks who are needing residential services, and our partners at CCOs to make sure that the information that we need to be able to provide the most appropriate services to individuals is all there. A critical piece of making sure that someone can receive the services and that providers can be reimbursed appropriately is really, really robust documentation. And that can come from folks providing that care coordination role. It can come from primary care providers. It can come from vocational rehab provider. It can come from all types of providers that individuals are seeing. And it's really critical for that warm handoff and that collaboration to be present. And so to me, that's the most important thing since I stepped into the role of being the home and community-based services policy manager, is that we need to make sure that we have set a table for this program where all of the relevant partners and players in someone's access to care can bring the relevant information to those who are making those determinations, so that we can really make sure the person is getting the services that they need with the right providers and in the right settings. And I do know that for folks who are dually Medicaid and Medicare eligible, that can be really challenging. I will admit that I am not the expert here in dually eligible individuals and how that impacts someone's eligibility for 1959 services. So really what I have been exercising with my team is in spaces where we don't know how someone's status or benefit packages are impacting their ability to receive services, to show up and listen, because y'all are the ones who are seeing that on a daily basis, seeing the challenges and the barriers that are put up for individuals and providers who are trying to help them, and getting down to the bottom of what is the sticking point, what needs to be unstuck, what policy needs to be changed, or what OAR needs to be updated, what contractor needs to be communicated with, to really understand where those processes are breaking down, or where there might not be processes established, because that is a reality that I think that we face. And so I am going to stop talking and see if there are folks who want to share anything as far as the populations that you serve, any feedback that I can take back to my team and my leadership, so that we can really try to understand where some of those processes have broken down and where we can try to make some improvements.
Hi, Cassie. This is Nirmala. I have a quick question.
Sure.
Is it okay, Janet and Jake, if I can ask a question? You know, often we send people with serious mental illness to aging services for eligibility, and they have a mental health diagnosis, and the folks there through the MED process say, no, they have, they have a mental illness. And so they make a referral to the community mental health program. Hey, go there for home and community-based services. So what you said is that they have to have an established diagnosis, correct? Of mental. So very often, I think APD doesn't have a clear understanding of that. They are deciding that, at their eligibility, and the person may not have that diagnosis, and they're sending them to community mental health programs where access can be, can take some time. And so there's like a breakdown then in between, people, they don't know which which program will serve them. So I don't know what, if anything, you are doing with our APD partners in kind of, I don't know, bridging this this kind of issue.
Yeah. So one thing that I learned about when I took this role was the kind of the breakdown in that process that you were talking about, Nirmala. And I'm sure folks on this call are familiar with it, but it's called a medical emotional disorder exclusion. Is the one part of the assessment process at APD that an individual goes through when they're referred for home and community-based services there. What I can say is that in the governor's requested budget for the next biennium, there is a policy option package that APD put forward to remove the medical emotional disorder exclusion. As y'all can imagine, because APD has had that in place for so long, the process to remove it and then to establish the appropriate infrastructure to be able to support folks who have mental health needs or behavioral health needs is quite extensive. So it's really encouraging to see that policy option package was included in the governor's requested budget. Please, everyone, keep your fingers crossed that it makes it through. And the other thing that I will say is the minute that I took this role, the first thing that we started doing was partnering with APD. And it's very clear that not only is there maybe a lack of clarity around our processes and what is required and what's needed to support individuals with mental health or behavioral health needs from the OHA perspective, we don't know a ton about the APD process either at OHA, at least from my perspective. And my team, again, is very new. So we kind of came out of the gate with this perspective of needing to collaborate, right? We serve very much overlapping populations, and as individuals start to age more rapidly in Oregon, we're going to see a lot of folks who are served both by aging services and by behavioral health. So there is really a need to, like yesterday, be more on the same page. We're doing that in a number of ways. So our home and community-based services roadmap development, which was done over the course of the last year and a half, was done in partnership with APD. So we identified many places where things like eligibility determinations, things like concurrent assessment processes and other policy guidance need to be developed. And they are organized in kind of short-term and medium-term solutions. Some of those things are going to require funding. So we are strategically thinking about what that is going to require and planning for future opportunities to request funding either of the legislature or of our Medicaid leadership to do that. I think I don't have to explain to y'all that having a decentralized program for Medicaid services makes it really challenging to navigate those barriers and those gaps. And we have just scratched the surface on what that can look like. And I see Ellen Penny's hand up, so I'm going to pause for a moment and see if Ellen Penny would like to jump in.
Not necessarily right at that point, but thank you so much for this great presentation. For those of you who don't know me, my name is Helen Pinney. I'm Principal Ombuds for the Oregon Health Authority, she, her pronouns. We work a lot in the space with dual eligibles who are very concerned and confused about transitions. We have advocated in our ombuds reports that the doorway through which all people with disabilities go to have their disability determined be one door, that disabilities are treated, that the services and supports folks with disabilities get are the same, regardless of disability. And I'm so grateful for Cassie's leadership in this arena because she shares that vision, although I think it's going to continue to be that OHA is home to the behavioral health determination through COMAGIN and CMHPs and APD and DD separately. I did want to say that one barrier we've seen for folks with behavioral health as their driving disability is this. If I have a physical disability, I have Medicare. I maybe have Medicare as a result of my disability. I have physical health disabilities. I qualify for long-term care services and supports. That qualification will often make me eligible for Medicaid, right? So that's what makes me a dual. Once I become Medicare eligible, I can only get Medicaid if I'm very low income, if I have, or if I qualify for long-term care services and supports, or if I'm an employed person with disabilities. The same is not true for folks with behavioral health. And that is a huge problem in this way. They don't qualify for Medicaid, even if they qualify for long-term care services and supports. I hope we can change that. That requires federal action. Not sure we're going to get much in that arena right now, but it is a huge disparity that the Ombuds program is concerned about because Medicaid is such a huge advantage for folks with disabilities. And we would like all people with disabilities who qualify for LTCSS, regardless of disability, to be able to get access to Medicaid if they qualify. So just wanted to put that out there, and great gratitude to Cassie, who's leading really great efforts in our agency to get it better. Thank you.
I want to pause. I didn't have much prepared, so I could go off the top of the head for a little bit longer if y'all want, but I also want to pause and see if folks have questions that I can answer regarding the care coordination for individuals or anything, really anything 1959 or home and community-based services related.
Cassie, what is OHA doing to build the workforce to provide 1959 home and community-based services? I'm sure others may want to know. I may know a little bit, but It's
Sure.
like a burning question many people.
Yeah. One of the things that I am still finding as we talk to providers all across the state, behavioral health providers of all kinds, is that there's still a lot of people who don't know about 1959 services. A lot of people are very aware of home and community-based services through APD or ODDS, and we have this tiny little program here at OHA that serves people with behavioral health or mental health needs, and not a lot of people know that. And so the main door that folks enter the home and community-based services universe through is through APD. And I think to some of the points that Ellen made earlier, and probably as some of y'all know, that is where a lot of the folks who are needing behavioral health focused home and community-based services tend to fall through the cracks. Because again, they are typically referred to community mental health programs, or excuse me, county mental health programs, especially if they don't have a mental health diagnosis. And obviously that can take a long time to procure. So just outreach and education about the 1959 program in general is still happening. We have office hours for county mental health programs, residential service providers, adult foster home providers, safety net clinics, including federally qualified health centers and certified community behavioral health clinics that are happening twice a month. We have engagements and webinars that are being scheduled out through the rest of the summer of 2025 and beyond. And before, without a team behind home and community-based services, there was really limited capacity to create any kind of guidance documents beyond what exists in our Oregon administrative rules. And we've heard loud and clear from providers that that is not sufficient. So we are working really hard to create some tangible resources just so that we can educate folks about 1959 and really help providers be able to understand the process of rendering those services, billing for those services, and things like that. And then I think once that education and outreach starts to ramp up, we will see an increase in folks who are providers who are interested and eager to provide those services, while OHA is able to provide technical assistance and support them in a way that is effective. I think the other part that people don't talk about a lot is personal care services. So for individuals who want to remain in their homes and communities rather than in institutional or other residential settings, we can provide personal care services for individuals. And there is an extreme shortage of personal care attendants for people needing 1959 services. So in partnership with ODHS and to increase the overall direct care workforce, we have a workforce recruitment campaign that is going on right now for home care workers, adult foster home providers, and personal care attendants as well. And that is happening in partnership with the Metropolitan Group and the Oregon Home Care Commission. And we also have, through 2024 legislation, the Agency with Choice program that is aimed at creating a new service model for in-home services that is more self-directed by the individual receiving those services, while an agency called an Agency with Choice really handles all of the administrative responsibilities. So making sure that the provider gets paid, their benefits are being covered, things that typically someone who, as y'all can imagine, folks with mental health or behavioral health needs might not be able to do, so that they can focus on actually directing their care. So those are a couple of things that are happening right now to increase our workforce and to better support our workforce, right? Increasing the workforce without the support to go alongside that is not super helpful. So we are really trying to establish resources that are helpful to providers, current providers and future providers, while we are also trying to expand the workforce. I see Ava has a question.
Hi, I love 1959. I've seen it work so well when I worked at Washington County. So I just want to kind of give kudos for the program that you do. Part of the conversation that I think you might have heard earlier around the MOU that Jennifer was going over was kind of this idea of like, who is in 1959? And in my experience working at the county, there wasn't really a centralized list, right? Like somebody was like signing off on the authorization, sending it back to you all, and then it kind of just disappeared. So for my knowledge, is there any way for you to generate lists of like who would be in each of our, say, regions or whatever assigned to each of our CCOs who would be in services with you? I think that that's the data, but Jennifer, from my understanding, isn't captured right now in the 834, right? But I think part of the reason I'm asking is because I know there's an idea that we, talk to behavioral health and things like that. But sometimes I think that even though, like if someone's at Cascadia getting treatment services, they're not aware necessarily always that there's a PCA or that the PCA is actually funded through this. And so kind of that's where I feel like because we're programmed so small and our community's not, well educated on how things are funded, we kind of end up in a.
Yeah, this is Jennifer. There were codes years ago that were in MMIS for 1915 when OHA coordinated it ourselves. It was also a very small program at that time because we had like one person working a fax machine to try, 20 hours a week or something. I mean, it was kind of terrible. So, so the idea is, yes, we've tried to open this program up, but in the process right now, what I understand from Cassie's team is that they have set up a process for Comagine to be able to bill in MMIS, but there is no coding. Like we couldn't go through MMIS and pull a code, and they are no longer using the codes that get pulled into the specific LTC LTSS code on 834 that we set up as the LTSS indicator. So those codes that are in the system are no longer used. So it's a kind of a question, yes, on how can Comagine work directly with CCOs. Now, Comagine has told me that they didn't feel CCOs wanted to get information when they've tried to send it in the past about members who had, and they wanted to coordinate. So hopefully this is an opportunity to build a new process under Cassie's new team that will really work for everyone and the members so that they can be pulled into that bigger concentration. And Cassie, under those new CCO rules, anyone with LTSS is supposed to have a more comprehensive care plan. And that would include that the CCO must, would know that that member has those services.
Yeah. So to speak on the codes a little bit, the codes that Comagine uses to authorize services for folks who are eligible for 1959 services are all going to be on our behavioral health fee schedule. There are individual codes, and there is also a modifier that goes along with those codes to show that individual is receiving those as a result of being eligible for 1959 services.
But they're being paid fee for service, so the CCOs will not have access to those. So this is why, our responsibility as fee for service is how do we translate all the LTSS services are carved out. So, this code, on the 834 was originally about trying to make sure the CCOs had that. So in lieu of that not working at the present time in the way it was intended originally, how do we try to get that pulled for CCOs, even if it's a paper list that goes out once a month or, I'm not sure what the process could be.
Georgia, before I jump in, I saw your hand up. Did you have anything that you wanted to share in regards to this process, or was it a separate question?
Are you talking to me?
No, I saw George had his hand up, so I wanted to pause before I jumped in.
Oh, this is George. Yeah, I did. I wanted to let you know, Cassandra, that I don't know if you were aware that the new One System had developed a new committee, and I'm one of the chairs that sits on this committee. And we had, when I got into it, some things were in disarray. And so with me and the crew that were on this new committee, I think it's going on a year and a half now, trying to make it streamlined and everything for CCOs and food stamps and stuff like that, as best as we could on the committee. We've got a lot of positive feedback, and I don't know if you could tell the difference in the One System as it stands now from what it was before?
You know, I don't have access to or go into the one system as part of the work that I do. We are working on getting some read-only access to our contractors. So CoMagine Health being one of them. And then as well, since these services are provided on a fee-for-service basis, we are working with the fee-for-service care coordination entity, Essentra, to be able to have read-only access to the one system as well. To I think to some folks at this point, including yours, George, to have a better understanding of what is being provided to an individual kind of comprehensively, including long-term services and supports, and including 1959 as a step towards a better and more comprehensive care coordination for individuals. And I'm going to drop this in the chat as well, but my team has also been working with our partners in the Health Policy and Analytics Division here at OHA to get better data on the individuals who are receiving 1959 services through our claims data. And we're working with our partners at APD as well to make sure that we are not missing any data from that perspective as well. The hope is to eventually be able to disaggregate it to a point where we can see, by certain populations, by regions, where those services are being rendered. And not just for folks receiving services, but who are the providers, right, in those regions, who are actually billing for those services, whether they're habilitative providers, psychosocial rehab providers, PCAs, to develop a really a more comprehensive understanding, again, of the universe of home and community-based services, both from the provider perspective and the network adequacy perspective, and for an understanding of who it is that we're actually providing these services to, who could be eligible, right, and how we can grow this program, because we know that there are many, many more people who are qualified for 1959 than are receiving services right now.
Thanks, Cassandra, for
I'd just like to add a comment, Cassie and Jake. In our mental health system of care currently in Oregon community mental health programs, we never had like a strong culture of providing home and community-based services. It was always, there was a small sliver of personal care, which was, I wouldn't say to scale. So it was very natural to think, hey, we have to send them to APD for the services. So I think there has to be this kind of huge shift in culture. You just mentioned, Cassie, that this is underutilized in our mental health system. I would say enormously underutilized. And so I think part of it is that culture change that needs to happen along with the education and awareness that this program exists. So I just wanted to highlight that.
Yeah, thanks, Nirmala. That's probably one of my biggest takeaways is seeing how valuable this program and the services that it provides could be, and seeing how underutilized it is going into different regions in the state, and having people absolutely not know what 1959 services are. That is, the service. It's kind of like that metaphor. If a tree falls in the forest but no one hears it, did the tree fall? If the services are available but no one knows about them, people don't get them. And so really we want to educate our communities, our providers, our advocates, our community-based organizations about 1959 services, which is where kind of the heart of my work always lives, is in that outreach and engagement space, because the more connections and the more relationships you build, the further your reach is. And that's really what our goal is to expand and grow this program so that we can serve as many people as possible.
I want to see if there was any other questions or comments for Cassie. Not seeing any or hearing any. Cassie, thanks for joining us today. We greatly appreciate it and the information you brought around the 1959.
Thanks for having me. I'll drop my email in the chat. If y'all have any questions at all, please don't hesitate to reach out to me.
Awesome. We did have one question get posted in the chat. Jennifer, I don't know if you can just confirm on the MOU report being due on 5/16 or 5/30. There might have been some confusion there, so just want to verify that.
Hold on. I might have given you the wrong day, so my brain cells are limited these days. All right, let me double check. It looks like we said May 30th, so my apologies if I mentioned May 15th. I believe I got that confused with the former TQS deadline date, which is different this year. The TQS attestations are due by the 15th, as I believe. So that's why my brain cells are messed up there.
No worries. Thanks for confirming. And Christy, thanks for posing the question. We are now at the point for public comment. We do have a couple minutes available, so I wanted to open it up for public comment if there is any. Just so everybody is aware, our next meeting is August 12th. Be on the lookout for an agenda for that one. Thanks everybody for joining today. Thanks to our presenters, as well as thanks to all those individuals that contributed to the meeting. I hope everybody has a great rest of your day and a good week.
Thanks, Jake.